unbelievable honor, one of the highlights of my career to give the inaugural Richard L. Lindstrom Medal Lecture. I'd kind of like to walk you through kind of how I got in my career here, my disclosure. So I grew up with 8 siblings, and we all had hardships growing up. We all had challenges, but none of us really had to bathe with 3 of your other brothers, but that's another Odyssey for another story. So my plan was to get into as good a residency as I could, and then, be a comprehensive ophthalmologist and then go to the western suburbs of Chicago, where most of my family was. And I was a big sports fan. All my teams were there, and the majority of my siblings were there. So part 1 of my plan, I mastered in ophthalmology at the University of Minnesota. I want to try to describe the first weeks in that practice. My first rotation was with Dick Lindstrom. He was seeing 100 patients a day, and this was July of 1981. We had infections and perforations and rejected transplants and chemical injuries and pemphigoid and Stevens-Johnson and then taking care and learning to take care of those patients. And then on the research side, Dick and Don Doofman had created what's called organ cultured cornea. Corneas were stored at 34 degrees centigrade, which allowed for elective corneal transplantation. All other corneal transplantation was done on call. You got a call and you had to get the patient in 24 hours. And Dick was seeing a patient and scheduling him in 3 or 4 weeks like we do now. At the same time, he was working on the next best corneal storage media, which would become Optisol, which today is still the most preferred media for corneal storage. He was working on new designs of posterior chamber lenses. He was, teaching the world phaco. He was involved in the first refractive surgery trial. And then after I remember on Tuesday mornings, we'd have our cornea clinics, and we go off to the clinic or conferences. We go off to the clinic, and then Dick would have these line of industry guys he was talking to, which really was unheard of back then. And so I'll never forget this change in career plan where Dick called me into his office as a second-year resident. He said, what do you want to do? And I said, I gave him my plan. He said, I don't think so. I think you should do a cornea fellowship. And I think you should come back and join me because we can work together. But he said, you can't do it here. You got to go somewhere else and bring me back something different. And so fortunately, I matched at the University of Iowa, a fantastic cornea program. And then I got a call January of that fellowship year, and I was kind of getting through, and he called me back and said, I don't think you can come back. He said, we have 3 corneal surgeons. We all do the same thing, general cornea, and we need something different. And get us a skill we don't have. And I want you to build a high-risk corneal transplant service, which was not heard of. So I was massively in debt. I had a 10-year-old Toyota car, and I wasn't very happy with that phone call. And I said, I'm going to call Dick back and convince him that that's a bad idea. And we all know the joyful Dr. Lindstrom. People like to spend time with Dick. But there's this serious Dr. Lindstrom. And those of you in industry who's ever been across the table know serious Dr. Lindstrom. I made that phone call. It lasted about a minute. And it was like, if you don't do the next fellowship, you're not coming back. So off to the National Eye Institute, which was an incredible year. We were using oral immunosuppression, not being used really in ophthalmology at all. We were learning how to use them and how to prevent inflammation. And really, that year absolutely changed the rest of my career and everything I do. Went back to Minnesota. We actually built a referral service on high-risk transplants. And we had a lot of successes, but actually we had more failures. And if we look at what was going on, we had 2 groups of high-risk patients. The patients that had a pretty normal eye, except they rejected their cornea, and we put them on oral immunosuppression, and we fixed that eye, and that did great. But there's the other group of patients that no matter what we did or what the level of immunosuppression, they kept rejecting and rejecting. And really, it was a group of patients that had chemical injuries and thermal injuries and Stevens-Johnson syndrome, and we couldn't figure out why. But I was getting a lot of these patients, and I wasn't fixing them. And then the discovery of this translational research of what are limbal stem cells and where they are in the eye. And if you don't have a population of stem cells, you can't rehabilitate a rejected cornea. And this is really, truly translational research. And so, fortunately, we understood that if with a lack of stem cells, we had persistent epithelial defects, we had conjunctival scoring and conjunctivalization of the cornea and inflammation. These patients had profound visual loss. They were in chronic pain, and you can't do corneal transplantation, a DALC or a PK, whatever you want to do. It'll fail 100% of the time. And unfortunately, these are the patients I was accumulating. And so now I got a lot of these patients that I can't help. And so a group of corneal surgeons throughout the world with that discovery came up with some operations to address it because it was a structural problem as well as an inflammatory problem. So the unilateral disease, conjunctival limbal autograft, taking limbal stem cells from the normal eye to the diseased eye, worked great, no immunosuppression. But then we had the bilateral patients. And so the first procedure was a cadaveric donor where we used donor corneas and keratolimmal allograft. And then finally, we started using living donors. And we started fixing these eyes. But then another challenge was we were using immunosuppression, but I still had a high rejection rate. And I can tell you what it was like at University of Minnesota. Nobody stayed later in the office than Dick. After his clinic, he'd be a stack of charts. It would be 7, 8 o'clock, and I'll be damned if I was going to be going home before Dick Lindstrom. But I remember going in his office, and I said, Dick, we're having some success, but I still am losing a lot of patients. And he said, we have the greatest transplant service, organ transplant service in the world here at University of Minnesota. I'm going to have you meet John Nigerian, the head of renal transplant, and you tell him your problem. And so what we finally came up with is, and what they told me was, you in ophthalmology really are not immunosuppressing. You have to be 100% all in, and this chart is messy, but it really kind of tells you all we have to do. So we took our patients and used exactly what was done in renal transplant, and all of a sudden, we started having great success. And you can see this evolution of immunosuppression. We used to use no drugs originally in the stem cell days, and then we used prednisone, and then we used a little bit of cyclosporin, but then finally embraced all of immunosuppression. But then we were having side effects in our patients. So we weren't rejecting, but the patients were gaining weight, they're having renal problems, and then we realized preoperatively we can do something. We can do a donor workup to see where they are, and we can adopt some of these inflammatory markers and change the way we do transplant. And what we changed was we started using living donors instead of cadaveric donors. Why were we using cadaveric donors? Well, it was easy. You didn't have to find a family member, and you didn't have to talk about operating on a normal eye. And that was a big struggle for a lot of corneal surgeons. They didn't want to take this tissue from a normal eye and bring it to a relative. But the success rate is much higher. So we then started individualizing immunosuppression. If I had a HLA identical donor, and a PRA is an inflammatory pre-op test we do, and their PRA was low, I didn't have to give them full immunosuppression. On the other hand, if I had no donor, I had to use a cadaveric donor, they had a high PRA, I had to use all the immunosuppression we had. So all patients didn't get the same immunosuppression. And then about that time in 2000, Dick had left the U of M. Of course, he was a lot smarter than me. He figured out the bureaucracies and the inefficiencies of academic medicine. And after talking to my wife, Lynette, I had this opportunity to go to Cincinnati. But the first thing I did was call Dick Lindstrom, and we made a dinner date at Manny's restaurant. Everybody knows Manny's restaurant, has ever worked with Dick. And we sat down. I didn't make the move until I talked to Dick Lindstrom. And it was really, for my career and my family, a great move. It was this unique collaboration between Cincinnati Institute and the University of Cincinnati. I had all the support of a big university, but I could practice in a private setting with efficiency. And we were able to build this incredible network where I actually couldn't do it at University of Minnesota. We partnered with St. Elizabeth Hospital, who hired me a transplant coordinator. I started working with Children's Hospital because we got kids referred in. And we built this team that's exactly based on organ transplantation. Now you need ophthalmologists, I need my retina specialist colleagues, I need glaucoma. We create a lot of glaucoma, oculoplastics, and we have to have an internal medicine nephrologist who does transplant immunology. But the glue is having a transplant coordinator. And no none of the corneal surgeons that are in this field had it. Now, why do we need a transplant coordinator? These patients have labs every 4 to 6 months. They have multiple appointments. They have a lot of questions, a lot of side effects. We right now have 550 patients immunosuppression, and we're tracking labs for 550 patients. A corneal surgeon can't do that. And so what have we learned as we've moved this to really modern day team approach? Well, we can have success. So we published back in 2012, 258 eyes, 125 were the worst eyes. They had conjunctival disease, not just pure limbal disease. And we showed that in a mean follow-up of 5 years, our success rate was over 70%. You can see this patient here had 4 previous failed corneal transplants. Nobody addressed the ocular surface disease. He had a living-related conjunctival limbal allograft combined with a cadaveric keratolimbal allograft because of the severity of the disease. 3 months later, gets a penetrating keratoplasty and, of course, on full immunosuppression. And here he is today with a clear cornea, and he's done well, and he's many years out. We get questions, well, these all fail eventually. Well, no, they don't. This is a patient actually from Houston. He's 16 years post-op of keratolimbal allograft, his only eye, and he's 20/40, and he's off immunosuppression. This is a patient from South Carolina who had a terrible thermochemical injury. He had this combined procedure, which we call the Cincinnati procedure. 12 years post-op, 20/30 vision, off immunosuppression. So we've actually shown that we can fix the eyes that had no chance in the past. The other criticism we get is that patients are told, you know, you have to live with your blindness, or you can go to this guy in Cincinnati, he'll put you on immunosuppression and you're gonna die. And the patients get told that all the time. And they come and see me and they meet the team, and I said, we have a third choice. You can come and have surgery, go on immunosuppression, get your vision back and live, and that's what we're gonna do, and that's what we've done. So to prove that we can use immunosuppression safely, we looked at 10-year data, 270 patients, 389 eyes. We have no deaths. We've had a couple secondary tumors that we've managed, 2 heart attacks, 1 pulmonary emesis, and really it is safe and we can use them, and we've been trying to convince ophthalmology of this. Overall, the team, and it's not me, I couldn't do it without retina, glaucoma, and our oculoplastic surgeons. We performed over 750 cases. We've got 885 publications in this field talking about what we do, how we do immunosuppression, and the individualization of the protocol. We've talked about how living-related donors are much better than cadaveric donors, just like in kidney. And then we started getting referrals of children. There's never been an ocular surface transplant with immunosuppression done in a child. We recently published 19 eyes in 13 patients. And the reason we can do that is we have a great children's hospital in Cincinnati with great nephrology support. But one challenge we have is very few corneal surgeons will adopt what we do. The surgery is challenging in that the surgeons don't like to operate on normal eyes. They don't get that rapport with internal medicine that we have, and I'm not sure why. The reimbursement is much, much less, and you certainly don't get paid for your time. And these patients take considerable time, and they don't have funding for a transplant coordinator. And then there's this fear of medical management that they have. So we've tried to put together, and I've had a lot of people kind of help me with this management concept of the Cincinnati protocol, where you adopt and embrace the organ transplant protocol, you partner with renal transplantation, you have funding for a transplant coordinator, and you build a team of specialists. And if you don't have the team of specialists, you certainly won't do it. We've been able to do it. And I've been able to have a lot of good people around me help, and we've formed a foundation to now create 7 or 8 centers around the country, and we're raising money right now to adopt this protocol. An individual cornea surgeon can't do it on their own, but I have a lot of good health, and we think we can get this thing going. So I've talked to my wife, and this is kind of how I was going to end my career, you know, in my last chapter. And then I got another call from Dick Lindstrom not too long ago, and he said, I got a project I'd like to discuss with you. It's called injectable endothelial cell therapy. So how could I turn that down? So what's the potential which we can grow endothelium, proliferate the cells, and inject them into an eye? One cornea can supply enough endotheliums for possibly hundreds of patients. It'll change eye banking all over the world. We can't take our eye banking system and really put it in the developing world. We have insurmountable problems with creating a traditional eye bank system. We can transport cells, we can't transport cornea. We have 12 million blind people in the world from corneal disease, and about 7 million are due to endothelium. We don't have 7 million corneas, but we probably can come up with 40 to 60,000 and get cells for those patients. So this work was based on the unbelievable work and idea of Shigery Kinoshita from Kyoto, in which he is a lifelong project where he grew these cells and then injected them into the patients. And he published his work in the New England Journal, which is amazing in and of itself to get an ophthalmology paper in New England Journal. His first publication was on 11 eyes, and he showed that he can reverse corneal edema. And if we look at the development, his second publication was five-year data in the AAO Ophthalmology Journal in 2020. And Dick and I now work with a company called Aurora Biotech, which is a division of CorneaGen, looking at a proof of concepts of Dr. Kinoshita's work. And we have had Part A and Part B of this trial. In November of 2020, we took down cells and we treated 16 patients at the Clínica Quesada. We want to thank the Quesada team of Gabriel and Rodrigo for working with us. The second time down was May of 2020. One donor cornea treated 34 patients. We're looking at primary corneal endothelial dystrophy. Just think about that. One cornea, 34 patients. And this is patient one in the November, and it's called the IOTA trial because we actually flew down during a Category 5 hurricane IOTA. We all had to figure out how to get there, but we didn't want to cancel. And so we are removing the damaged endothelium. We're going to then inject with Vision Blue to stain decimates. We don't want to leave any abnormal endothelium. We then flatten the chamber, and we take a solution of cells that have been resuspended, about 1 million cells. We're going to inject it in a watertight incision and fill the anterior chamber with a new suspension. The patients then go face down in the recovery area and for 3 hours. Liz Yu is part of the team, John Berdal, many great corneal surgeons go down there with us. So this was patient one. So I'd like to show you pre-op, 2,500, corneal thickness 800, 6 months post-op, 2040, corneal thickness 500. A couple other patients, 22,000, corneal thickness 891, best corrected visual acuity 2030, central thickness 557. That was probably Liz, she gets better results than I do. Another patient, 22,000, pre-op 874, 6 months post-op 2050, 584. So what does this therapy potentially mean? So first of all, in our proof of concept, we've now treated 50 eyes with 2 donors. So the efficacy seems to be there. We're planning further trials in the US for approval. It has the potential to be the treatment of choice of all endothelial disease. And really what excites us is this potential to be the solution to world corneal blindness, which we don't have. So, Dick, it's been an amazing journey from the day I met you as a first-year resident, my first rotation. I knew you're a once-in-a-lifetime clinician, surgeon, and teacher, and certainly an innovator. And you have had an incredible influence on patients, surgery, and all the aspects you've heard here, cataract, refractive, cornea, on science and researching, eye banking. And you actually changed the paradigm for the ophthalmic industry and made it okay for physicians to work with industry. There's not been a more influential ophthalmologist in our generation, and there actually isn't second place. I have never made a move in my career without your wise counsel, and your advice has always been as good as gold. So thank you for all you've meant to me, my family, my colleagues, and ophthalmology. It's an honor to call you teacher and mentor, but a greater honor to call you friend.